saying that it looked like it was obvious then. It's not obvious. I am still thinking about it, and I think that there are good reasons in favor and good reasons for being quite concerned. But to start the story with the reality, last week I was with neuroradiologists. They were preparing for a big European meeting. And the main issue was, do we really believe that in the next 10 years, the same doctor will be capable of doing NMR 7 Tesla and concentrating in prenatal diagnosis with the mother and doing interventional neuroradiology? Of course, we will not. So that is a general trend for medicine. And I think that what we are saying today mimics when 40 years ago, internal medicine was objecting to the cardiologist. Cardiologist doesn't exist. It's internal medicine. Nephrology doesn't exist. Then they start doing bone marrow transplants and immunology. And so I think that there are really reasons for being open rather than believing that it's obvious. As Danielle has done, I think that we should try to define things. So my understanding is that we have to talk about the patients, the place, the location, the people, and of course I will put my finger on you. That I think the most relevant factor, and I don't like protocols, so a way of organizing our work. And to be realistic, in the world, there are different solutions already in place. So we can have a very general ICU, which has no specialties, is simply at the general. Then what we can say the multidisciplinary. So there are different competencies, and then there is a general and neuro combined, or extremely specialized NeuroICUs. But that may happen having as the core staff simply the nurses. And in many USA situations, that is the situation. You have the nurses and residents and consultants, people coming and giving their own opinion. I was scandalized. I was in Richmond, and I was not allowed to touch the ventilator, respiratory therapist. So that was a kind of separation of competencies that I didn't like. Then there is the other organizational possibility. So you have the ICU with the ICU staff. So you have your own doctors, so many specialists. And in this situation, you can have the Fabio, the David, so people with special neuro competency that may help into the general setting with some special knowledge that they have to the situation, or running their own NeuroICU. So we have a spectrum of possibilities. Do we have any convincing demonstration that the different models are really better, different possibility? We don't. So I simply selected some of the papers, and I will try to present how they can be stimulating, but they are not, I think, the final answer. So let's start with this one, which is by Jose Suarez, who is a neurointensivist, and says, okay, if you do a specialized neurocritical care team, so we have people who know what they are doing, patients do better. And if you look here, no ICU team or ICU team, much better. Michael Dieringer, quite a long time ago, 15 years ago. Intracerebral hemorrhage. Does it make any benefit to go in a specialized center? And of course, Michael was looking at a kind of big exercise, 42 versus 1, so on, more than 1,000 patients selected in 3 years. And Michael was saying, there is a gap between being with people who are knowledgeable, so we are not talking exactly about neuro against, but people who know what they are doing. Okay, good. And that, 15 years later, has been confirmed. This paper is important because it says that by putting patients where specialized treatment is available, is cost effective. We are treating them in a better way, and we still save money. It is reassuring. So what about historical perspectives? Because most of those papers say that there was a before and after. So I think this critical care paper coming from Uppsala that I think it's worth looking at because it says something that we would like to believe, but I think is not supported by the findings. Look here. So NeuroICU was about ICP, CPP, PCO2, PO2, so good general care plus brain. And the author decided to split in 3 time periods the patients they got. But please read carefully the last line. The proportion of patients with the motor Glasgow Coma Scale equal or better than 4. They were 40% at the beginning, 92% after. So the before and after can't really be used for any comparison because, of course, what they have shown, the patient do better. But the point is that the patients were not as severe as they were before. So to talk about improvement is not enough to say that there wasn't something more favorable because with the same severity, you should demonstrate some improvement rather than saying that they were less severe and they did better. I don't think that this paper really proves something. So we are still short of demonstration. This is neurocritical care saying, okay, having patients in an NeuroICU means that the patients are submitted to a different management compared to being in the general. And to my disappointment, no, they say, of course, is in favor of the NeuroICU, but I don't believe this. Receive less IV sedation. That doesn't apply in Milano. When we have a severe ICP problem, we are quite strong in sedation, so it's not applicable to me. Then I think that we have more convincing papers, because in this case, from the UK, the authors were looking at secular trends, so big changes over time for some specific intracranial or neurological problems. And I would like to share with you this graph, because I think that in this case, the graph is based on more than 10,000 patients with intracerebral hematoma. It's 10,330. And in this plot, you see that they have divided the patient looking at the acute mortality, which is a very rude way of saying severity and outcome, but it says a lot. And you see general versus narrow ICU, and they split also into the general ICU, where the neuro support was limited, meaning you can call someone and they will come 1 day later. Or you may have people that you trust and that is there with you and you can share the problems. And it looks like there are differences. I am not talking about statistics, but it's a lot of numbers, a lot of patients saying that probably if we apply the right knowledge, we do something good for them. This is a very difficult paper by David Nino. Difficult because I think it's so complex that it's difficult to catch the best. But the best I could do was try to understand that if you look at the fate of the patients and you try to say, okay, we do something for them, then what happens then? And the idea is we may have a measurement of the, let's say, good quality of life and the years of good quality, acceptable quality of life that they may receive by treatment. Then, if I understood properly, and you see here a lot of ICUs with different scenarios, so a different combination of possibilities, dedicated neurocritical care units at higher mean life, quality adjusted life here, a small additional mean cost. So we are not cheap. In this situation, we may ask for more money. Then we can provide better results for the patient. And again, David and others pointing at what I think is the most fundamental aspect. So let's say that we all agree that we better know what we do. So knowledge of the treating group is essential. And my point is that knowledge is becoming so complex and so huge that there is no way to have someone who knows everything. So of course we need to work together. But also in this case, the second factor is that the more patients you treat, the higher the caseload you are exposed to, the better you perform. And that has been proven in, I think, many pathologies, and in this case, in subarachnoid hemorrhages. There are many papers proving that if you do less than one case per week, your results are not comparable with the good centers. Again, in favor of the multidisciplinary, I started my presentation saying that I am not sure about the right solution. So for sure, we will need a lot of patients. Then we need to be exposed, having a lot of knowledge, and by necessity, we have to work all together, trying to make sense of what we have. Perhaps then, now we may concentrate, and that is my final point, on the people. And I think that the answer to the question should be, do we need it or we don't need it? Do we need an NeuroICU? We don't need it. Depends on the goals that you have. For my taste, I don't think that the model with very specialized units apply everywhere. I don't think so. But if we have a big academic hospital where we try to educate people and to build up the medicine for the next decades, we do need to be extremely specialized. And in these 2 or 3 final slides, I will try to put the pros and cons of the 2 possible solutions. So for sure, on one side, on the left, let's say the general ICU, but the way Danielle had described it, having different people with different knowledge, different competencies, working all together. So it's a team effort. And on the right, NeuroICU. If you work in a very specialized, focused environment, you are more exposed to specific caseload, which has a very undesirable drawback, which is you are less exposed to other problems by definition. So perhaps you are also less exposed to new ideas, new concepts, or to the contamination. I can discover something that has been applied in different fields. What about the education? If we want to provide a very wide education, a very specialized unit is not the best place to be. So let's be fair and say that for these 3 aspects, there are pros and cons. But I think that just to conclude, if you want to use extremely sophisticated CNS monitoring tools, which means that you don't just put the catheters on the probe, but you collect the data and try to make sense of the data. For microdialysis, it takes, that is my experience, it takes twice the time to understand the data than to acquire the data, if you want to make sense of what you see. Then, if you want to be really tested in the most difficult cases, and as Danielle was describing, when there is something really tough, they call, and you do that. I think that also happens with ECMO. If you have a network, the really difficult cases should go where the expertise is concentrated. If you want to have a deeper CNS education, and if you want to do CNS research, I think that there is no escape. You have to work in a very specialized environment. And that is the final slide, because the speaker is Sandra Magnoni. And this man is the big neurosurgeon. And if you look at the screen, you will see it's an angiography. So once per week, we spend 1 hour, a couple of hours, talking about the very difficult cases. And we have neurologists, neuroradiologists, neurosurgeons, students, residents, researchers, and people. And we are focusing on very, very subtle details, because there is the place where we have time and we have the privilege of going in depth for specific problems. I can't say that this is the ideal, but